Although dying is part of the normal life cycle, it is often feared as a time of pain and suffering. The dying process is an opportunity to change a potentially difficult situation into one that is tolerable, peaceful, and meaningful for the patient and the family left behind. After this lesson, you will be able to assess patients for signs and symptoms related to the end of life, explain how to provide evidence-based end-of-life care for the dying patient, incorporate the patient's cultural practices and beliefs when providing care during the dying process and death, explain the purpose and procedure for advanced directives, describe the importance of collaborating with members of the interdisciplinary team when caring for the dying patient and family or other caregivers. Discuss the ethical and legal obligations of the nurse with regard to end-of-life care. And assess and plan interventions to meet the dying patient's needs. So for a brief overview, we're going to discuss the concept of good death and bad death. Good death stands for peaceful and meaningful, and bad death stands for death without dignity. Death is the cessation of integrated tissue and organ function, manifested by cessation of heartbeat, absence of spontaneous respirations, or irreversible brain dysfunction. In 2004, there were over 2 million deaths in the United States. And the most common cause of death is disease of the heart, followed by cancer. Of all people who die, only a few die suddenly and unexpectedly. Most people die after a long period of illness with gradual deterioration until an active dying phase occurs before the death. So let's discuss advanced directives. Most people would prefer to die at home, providing the type of care a person prefers, including where he or she wants end-of-life care. Positively affects the dying experience for both the patient and the family. The preferences need to be written as legal documents, and they are called advanced directives. So the definition of an advanced directive is written document prepared by a competent individual specifying what, if any, extraordinary actions the person would want when they no longer are capable of making decisions about their personal health care. There are two types. One type is DPOA, Durable Power of Attorney. This is a legal document assigning decision-making power to another person to make his or her healthcare decisions in the event that they are unable to make decisions or verbalize their decisions. And the other advanced directive is a living will. This is a legal document that instructs physicians and family members about what life-sustaining treatment a person does or does not want at some future time if they are unable to make their own decisions. So the desired outcome of an advanced directive in end-of-life care is to identify the patient's needs, for the patient to have control of symptoms of distress, to promote a meaningful interaction between the patient and the family, and to facilitate a peaceful death. Interventions are planned to meet the physical, psychological, social, and spiritual needs of patients using an interdisciplinary approach. So let's discuss hospice and palliative care. Hospice care is an interdisciplinary approach to assess and address the holistic needs of patients and families to facilitate quality of life and a peaceful death. Palliative care is a philosophy of care and an organized, structured system for delivering care for individuals with a life-threatening illness. The goal of the palliative care is to prevent and relieve suffering and to support the best possible quality of life for patients and their families, regardless of the stage of the disease or the need for other therapies. In other words, if a patient is receiving hospice or palliative care or have orders of DNR, this does not mean we do not treat the patient. This just means that you do not do any extreme life-saving measures. You still treat the patient for comfort. So let's talk about some end-of-life care. such as symptoms. As death nears, patients often have signs and symptoms of decline in physical function. They manifest as weakness, anorexia, changes in cardiovascular function, changes in breathing patterns, changes in gastrointestinal function, changes in genitourinary function. And collaborative care will include an assessment. Through the physical assessment, you're going to see clinical manifestations such as coolness of extremities, increased sleeping, a decrease in fluid and food intake, incontinence, and maybe even congestion and gurgling. So the physical assessment includes breathing pattern changes, disorientation, and maybe even restlessness. Psychosocial changes can include fear, anxiety. You want to take into considerations cultural beliefs and values and bereavement. You also will take into considerations feelings of the patient and significant others. For weakness management, you want to provide aspiration precautions. You want to provide mouth care and moisten the lips often. There will be altered routes of medication administration if needed. And you want to choose the least invasive route of medication administration with the most effective treatment. Pain management. Pain is the symptom that dying patients fear the most. Pain medication should be scheduled to prevent any recurrence of pain, and you want to consider alternative routes of pain medication administration as needed. It still needs to be the least invasive but most effective. Then we also have complementary or alternative therapies such as massages, music therapy, therapeutic touch, and aromatherapy. For dyspnea management, you want to treat the primary cause and relieve the psychological distress that accompanies the symptoms. Some of the pharmacologic interventions include opioids, anticholinergics, bronchodilators, sedatives, corticosteroids, oxygen therapy, diuretics, or even antibiotics. Some other methods you could use that do not include pharmacologic interventions are cool air, wet cloths to the patient's face, positioning of the patient to facilitate chest expansion, frequent rest periods, and encouraging imagery and deep breathing. Patient may experience nausea and vomiting, and we can manage that through antiemetic agents, remove any source of odors that are offensive to the patient or causing the nausea and vomiting. You want to provide a comfortable room temperature. You may need to make dietary changes, and you need to assess for and treat any constipation. Okay, so let's discuss some signs and symptoms of death approaching. We have restlessness and agitation management. You want to assess for pain, urinary retention, constipation, or another reversible cause. You want to treat the underlying cause. You can use pharmacologic agents or complementary and alternative therapies such as music therapy or aromatherapy. You may need to provide seizure management through pharmacologic therapy. There may be refractory symptoms of distress management and this will be done through drug therapy. It's the ethical responsibility of the nurse in caring for patients near death to follow guidelines for drug use to manage symptoms and to facilitate prompt and effective symptom management. Then we also have psychosocial management, which would include presence, life review, reminiscence, spirituality, and even religion. So briefly, some common emotional signs of approaching death that the patient and family may experience that you could provide education on is withdrawal, vision-like experiences, or them letting go or saying goodbye. Once the patient has passed, then we provide post-mortem care. There are legal considerations such as a death certificate, determination and the need for an autopsy, and the transfer of the body. Chart 9.6, page 119 of your textbook provides the best practice for post-mortem care. Previously, in one of the other lessons, we discussed euthanasia. I'm going to go a little bit more into detail about euthanasia. This is withdrawing or withholding life-sustaining therapy. There is passive euthanasia, and that's discontinuing one or more therapies that might prolong a life of a person who cannot be cured by the therapy. Another phrase used is letting the person die naturally or allowing natural death. Then we have active euthanasia. These are medications or treatments that are provided that purposefully and directly cause the patient's death. It is not supported by most professional organizations, including the American Nurse Association. In the states of Oregon and Washington, physician-assisted suicide is legal in certain situations. Nurses should not be involved in active euthanasia or physician-assisted euthanasia. They do, however, play a major role in the end-of-life care by advocating for patients' wishes and ensuring quality symptom management and support at the end of life. Table 9.3, page 119 of your textbook provides ethical concepts related to euthanasia. This concludes the lesson End-of-Life Care. If you have any questions related to this lesson content, contact the instructor.